Block simulation. 3. You know the drill. Read the command first, scan for the buzzwords, build the differential, lock in and move. 20 questions, 30 minutes. Start the clock. Read the command, most likely diagnosis, microcytic anemia, low ferritin, high TIBC, low transferrin saturation, menorrhagia, vegetarian, iron deficiency anemia. Iron deficiency is the most common cause of microcytic anemia. The iron studies are definitive. Ferritin is the body's iron storage marker. When it is low, iron stores are depleted. TIBC transferrin rises because the liver makes more transferrin to scavenge what little iron remains. Transferrin saturation falls. Koidonychia, spoon nails, and pica are classic late signs. Anemia of chronic disease, choice A, has LOW, TIBC, and Hig, or normal ferritin iron is sequestered, not absent. That is the key distinction. Beta thalassemia minor has normal high ferritin and a normal RDW with a low MCV out of proportion to mild anemia. Low ferritin is specific to true iron deficiency. Read the command, explain the hypoxemia. Opioid overdose, low respiratory rate, high PaSiO2, low PaO2, and crucially, a normal AA gradient. This is the highest yield concept in respiratory physiology. The AA gradient separates the causes of hypoxemia. If the AA gradient is normal, the lung itself is fine. The problem is either hypoventilation or low inspired oxygen. Opioids suppress the central respiratory drive. The patient is not breathing enough. CO2 rises, and because alveolar oxygen is displaced by CO2, PO2 falls. But the gas exchange surface works normally, so the gradient between alveolus and artery stays normal. The other choices, shunt, diffusion limitation, BCQ mismatch, all widen the AA gradient because they involve a problem at the gas exchange interface. A normal gradient rules them all out. Naloxone reverses the respiratory depression and corrects everything. Read the command. Which enzyme is deficient? Severe fasting hypoglycemia, hepatomegaly, lactic acidosis, hyperuricemia, hyperlipidemia, doll-like face, von Gierke disease, glycogen storage disease type 1. Von Gierke disease is a deficiency of glucose 6-phosphatase, the final enzyme in both glycogenolysis and gluconeogenesis that frees glucose from glucose 6-phosphate for release into the blood. Without it, the liver cannot export glucose during a fast, so severe fasting hypoglycemia results. Glucose 6-phosphate backs up and is diverted into glycolysis producing lactic acidosis and into pathways raising uric acid and triglycerides. Glycogen and fat accumulate in the liver, causing hepatomegaly. Choice B, acid maltase, is Pompe disease. Lysosomal, causes cardiomegaly and hypotonia, not fasting hypoglycemia. Choice C, myophosphorylase, is McArdle, muscle only, exercise intolerant, no hypoglycemia. The combination of hypoglycemia plus lactate plus uric acid is specific for von Gierke. Read the command. Which structure was injured? Femoral catheterization, weak knee extension, sensory loss over anterior thigh and medial leg, femoral nerve territory. Remember the mnemonic for the femoral triangle: lateral to medial, navel, nerve, artery, vein, empty space, lymphatics. The femoral nerve lies just lateral to the femoral artery. The femoral nerve innervates the quadriceps for knee extension and supplies sensation to the anterior thigh. Its terminal branch, the saphenous nerve, supplies the medial leg. Injury produces exactly this picture: weak knee extension, lost patellar reflex, and anteromedial sensory loss. Choice B, obturator nerve, controls thigh adduction and supplies the medial thigh, not knee extension. Choice E, lateral femoral cutaneous, is purely sensory to the lateral thigh, neuralgia paresthetica, no motor loss. The motor deficit in knee extension localizes precisely to the femoral nerve. Read the command, pathologic process underlying this. 70-year-old smoker, pulsatile abdominal mass, hypotension, tearing pain to back, 7 cm infrarenal aorta with fluid, ruptured abdominal aortic aneurysm. Abdominal aortic aneurysms are overwhelmingly atherosclerotic in origin. Atherosclerosis damages and weakens the tunica media, the layer that provides tensile strength. Chronic inflammation, matrix metalloproteinase activity, and loss of elastin and smooth muscle thin the wall. The infrarenal aorta is most vulnerable because it has fewer vasa vasorum and high pulsatile stress. When wall tension exceeds wall strength, the aneurysm ruptures, sudden tearing pain, hypotension, and retroperitoneal hemorrhage. Choice A, cystic medial degeneration, causes thoracic aneurysms and dissection in Marfan and connective tissue disease, not infrarenal AAA. Choice D, syphilitic aortitis, affects the ascending aorta and arch with tree bark intima, not the infrarenal segment. Location plus risk factors point to atherosclerotic AAA. Read the command. Identify the disturbance and the anion gap. Type 1 diabetic, no insulin, hypoglycemia, ketones, low pH, low bicarbonate, diabetic ketoacidosis. First, the primary disturbance, pH 718, is acidemic. Bicarbonate is low at 9. That is a metabolic acidosis. Pasco 2 is 22, appropriately low. Respiratory compensation, Kussmaul breathing. Now calculate the anion gap, sodium minus chloride minus bicarbonate. 34 minus 9 equals 29. Normal is about 12. So this is a high anion gap metabolic acidosis with a gap of 29. The unmeasured anions here are the ketoacids, beta-hydroxybutyrate, and acetyl state. Remember MUD piles for high gap acidosis: methanol, uremia, DKA, propylene glycol, iron IH, lactate, ethylene glycol, salicylates. Management of DKA, IB fluids, insulin, and careful potassium repletion. Read the command, mechanism of action of warfarin, atrial fibrillation, warfarin, INR monitoring, vitamin K dependent factors. Warfarin inhibits vitamin K epoxide reductase, BKOR. This enzyme regenerates the reduced active form of vitamin K. Reduced vitamin K is the cofactor for gamma carboxylation of glutamate residues on factors 2, VI, I-ANX, and X, plus proteins C and S. Without carboxylation, these factors cannot bind calcium and are functionally inactive. Warfarin is monitored with the INR. The antibiotic raised the INR by killing gut flora that produce vitamin K and by inhibiting CYP2C9 metabolism of warfarin. Choice A is dabigatran, a direct thrombin inhibitor. Choice C is heparin, which activates antithrombin 3. Choice D is rivaroxaban or apixaban, direct factor, XR inhibitors. Choice E is aspirin. Each anticoagulant hits a distinct target. Know them cold. Read the command. Source cell type, old man, bone pain, lytic lesions, hypercalcemia, renal failure, anemia, M spike, rouleau, Benz-Jones protein, multiple myeloma. Multiple myeloma is a malignant proliferation of plasma cells, terminally differentiated B cells that produce antibody. The neoplastic plasma cells secrete a single monoclonal immunoglobulin, the M spike, most often IgG. They cause the CRAF features, hypercalcemia, renal failure from light chain cast nephropathy, and the Bence-Jones protein, anemia from marrow replacement, and bone lytic lesions as plasma cells activate osteoclasts via Rankel. Rouleau formation, red cells stacked like coins, results from the high circulating protein. Choice A, mature B lymphocyte, is the source of CLL and most lymphomas, not the antibody secreting M spike of myeloma. Choice C, myeloid blast, is AML. The monoclonal immunoglobulin spike is the signature of a plasma cell malignancy specifically. Read the command, which virulence factor inhibits host protein synthesis? Cystic fibrosis, oxidase, positive gram, negative rod, blue-green pigment, grape odor, biofilm, Pseudomonas aeruginosa. Pseudomonas aeruginosa. Exotoxin A inhibits host protein synthesis by ADP, ribosylating elongation factor 2, EF2. This is the identical mechanism to diphtheria toxin. Inactivated EF2 cannot translocate the ribosome along mRNA, halting translation and killing the host cell. This is the answer to the specific question: protein synthesis inhibition equals exotoxin. Protein synthesis inhibition equals exotoxin A. The other factors are real, Pseudomonas virulence mechanisms, but do different things. Pyocyanin generates reactive oxygen species and the blue-green color. The alginate capsule forms the protective biofilm in CF lungs. Phospholipase C degrades membranes, and LPS triggers septic shock. Only exotoxin A targets protein synthesis via EF2. Read the command, mechanism explaining the diarrhea, multiple refractory ulcers, high gastrin not suppressed by secretin, pancreatic mass, Zollinger-Ellison syndrome, a gastrinoma. Gastrin from the tumor drives the parietal cells to secrete enormous amounts of gastric acid. That acid overwhelms the duodenum. Two consequences cause diarrhea. First, the low pH inactivates pancreatic lipase, so fat is malabsorbed, reducing steatorrhea. Second, the huge acid fluid load and mucosal injury impair absorption. The acid also explains the recurrent distal ulcers, even in the jejunum, which is unusual and a tip-off. The secretin stimulation test is the classic clue. Normally, secretin I inhibits gastrin release, but gastrinoma cells paradoxically I secrete gastrin in response to secretin. Gastrinomas are associated with ME1, parathyroid, pituitary, pancreas. Read the command, target antigen of the antibody. Hemoptysis plus rapidly progressive glomerulonephritis, linear IgG along the basement membrane, Goodpasture syndrome, anti-GBM disease. Goodpasture syndrome is a type 2 hypersensitivity reaction. Autoantibodies target the alpha-3 chain of type IV collagen, a structural component of basement membranes. This collagen is found in both the glomerular basement membrane and the alveolar basement membrane, which is why the disease attacks two organs: the kidneys, rapidly progressive glomerulonephritis with crescents, and the lungs, alveolar hemorrhage, hemoptysis. The linear pattern of IgG deposition on immunofluorescence is the signature. Antibody bound smoothly along the entire membrane. Choice A, PLA2R, is membranous nephropathy. Choice C, double-stranded DNA, is lupus, which shows a full house, granular pattern, not linear. Choice D, myeloperoxidase, is MPO, ANCA-vasculitis, which is pauciimmune with innoimmune deposits. The linear pattern is unique to anti-GBM. Read the command. Which nerve is compressed? Numbness in thumb, index, middle fingers, worse at night. Thenar atrophy, positive Tinel sign at the wrist. Carpal tunnel syndrome. Carpal tunnel syndrome is compression of the median nerve as it passes under the transverse carpal ligament at the wrist. The median nerve supplies sensation to the palmar thumb, index, middle, and half the ring finger, and motor innervation to the thenar muscles, the loaf muscles, lateral two lumbricals, opponens pollicis, abductor pollicis brevis, flexor pollicis brevis. Compression causes the classic sensory distribution, nocturnal symptoms, thenar atrophy, and weak thumb abduction. Associated with repetitive use, pregnancy, hypothyroidism, and acromegaly. Choice A, ulnar nerve, supplies the little and half the ring finger and the hypothenar muscles, compressed at the elbow or Guillain canal, not the carpal tunnel. The thumb index middle distribution with thenar atrophy is specific for the median nerve. Read the command. Positive predictive value. PPV is the probability that the person with a positive test truly has the disease. Build the 2x2 table. PPV equals true positives divided by all positives, true positives plus false positives. True positives are 90, the diseased people correctly flagged. False positives are 180, the healthy people incorrectly flagged. So PPV equals 90 divided by 90 plus 180, which is 90 over 270, which is 1/3, 33%. The trap is choice A, 90%, which is the sensitivity, true positives divided by all diseased. PPV and sensitivity are different. PPV depends heavily on disease prevalence. In a low prevalence population, even a sensitive test produces many false positives, dragging PPV down. That is exactly what happened here. Read the command. Underlying enzymatic defect. Developmental delay, musty odor, fair skin, eczema, high phenylalanine, low tyrosine, phenylketonuria. Phenylketonuria is a deficiency of phenylalanine hydroxylase, the enzyme that converts phenylalanine to tyrosine using the cofactor tetrahydrobiopterin. Phenylalanine accumulates and is shunted to phenylketones, producing the musty or mousy body odor. Tyrosine becomes essential and falls, and because tyrosine is the precursor of melanin, patients have fair skin and hair. Excess phenylalanine is neurotoxic, causing intellectual disability if untreated. Treatment is dietary restriction of phenylalanine and avoidance of aspartame. Choice B, homogentisate oxidase, is alkaptonuria, dark urine, ochronosis. Choice C, tyrosinase, is albinism, no melanin but normal, phenylalanine. Choice D is maple syrup urine disease, the specific elevation of phenylalanine with low tyrosine points to phenylalanine hydroxylase. Read the command. Embryologic cell type of origin. Episodic hypertension, palpitations, sweating, elevated metanephrines, adrenal mass. Pheochromocytoma. Pheochromocytoma arises from chromaffin cells of the adrenal medulla, which are derived from the neural crest. These cells synthesize and secrete catecholamines, epinephrine and norepinephrine, producing the classic episodic triad of headache, palpitations, and diaphoresis with paroxysmal hypertension. The diagnostic test is plasma and urinary metanephrines, the breakdown products of catecholamines. Follow the rule of 10% bilateral, 10% extra-adrenal, 10% malignant, 10% familial, associated with EME2, von Hippel-Lindau, and NF1. Choice A, zona glomerulosa, gives rise to aldosterone-secreting adenomas, Cohen syndrome, adrenal cortex, not medulla. Critical management point. Before surgery, give alpha blockade with phenoxybenzamine first, then beta blockade. Never beta block first, or unopposed alpha stimulation causes hypertensive crisis. Read the command. Pressure volume loop change. Elderly, angina, syncope, dyspnea, harsh systolic murmur radiating to carotids, delayed carotid upstroke, pulsus parvus et tardus, calcified valve, high gradient, aortic stenosis. In aortic stenosis, the left ventricle must generate very high pressure to eject blood across the narrowed valve. On the pressure volume loop, peak systolic pressure rises dramatically. The ventricle works against the fixed obstruction. To compensate for this chronic pressure overload, the ventricle undergoes concentric hypertrophy. Walls thicken, the chamber stays the same size or shrinks, and compliance falls. Despite the hypertrophy, stroke volume eventually declines as the obstruction worsens. The triad of angina, syncope, and dyspnea in aortic stenosis signals poor prognosis without valve replacement. Concentric hypertrophy reflects pressure overload, sarcomeres added in parallel. Contrast with aortic regurgitation, a volume overload that causes eccentric hypertrophy with a dilated, more compliant ventricle. Read the command. Which concept is illustrated? Right-sided colon cancer presenting with iron deficiency, anemia, sequential APC, then KRAS, then TP53 mutations, the adenoma-carcinoma sequence. Colorectal cancer classically develops through the adenoma-carcinoma sequence, a stepwise accumulation of mutations transforming normal mucosa into adenoma and finally carcinoma. The order is testable. APC loss comes first, initiating adenoma formation. KRAS activation drives adenoma growth. Loss of TP53 and other tumor suppressors enables progression to invasive carcinoma. The mnemonic is APC, KRAS, then P53 or AK53. Right-sided cancer is often present with occult bleeding and iron deficiency anemia, whereas left-sided present with obstruction and changes in stool caliber. Choice A, microsatellite instability, is the alternative pathway seen in Lynch syndrome from mismatch repair gene defects. A different mechanism. Choice C is wrong because colorectal cancer requires multiple sequential hits, not one. The ordered APC KRAS P53 progression defines the adenoma carcinoma sequence specifically. Read the command mechanism of action and site of toxicity. Gentamikin, an aminoglycoside, with acute tubular necrosis, muddy brown cast, and ototoxicity. Hearing loss, tinnitus. Aminoglycosides, gentamicin, tobramycin, amikacin, bind irreversibly to the 30S ribosomal subunit, causing misreading of mRNA and blocking the initiation complex. They are bactericidal and require oxygen for uptake, which is why they are ineffective against anaerobes. Their two signature toxicities are nephrotoxicity, classically acute tubular necrosis with muddy brown granular cast, and ototoxicity, both cochlear hearing loss, tinnitus, and vestibular imbalance. The toxicity is dose-dependent and accumulates over days. Choice A, 50S inhibitors, are macrolides, chloramphenicol, clindamycin, linezolid. Choice D, DNA gyrase, is fluoroquinolones, which cause tendon rupture. Remember, by AT30, CCEL at 50. Aminoglycosides and tetracyclines hit 30S. The ATM plus ototoxicity combination is specific to aminoglycosides. Read the command, organism, and treatment. HIV with CD4 of 1TD, subacute dyspnea, dry cough, bilateral interstitial infiltrates, high LDH, disc-shaped cysts on silver stain, pneumocystis jirovecii, pneumonia. Pneumocystis jirovecii. Pneumonia is the classic opportunistic infection when the CD4 count falls below 200. The presentation is subacute, progressive dyspnea, non-productive cough and characteristically oxygen desaturation with exertion. Chest X-ray shows diffuse bilateral interstitial infiltrates. LDH is elevated, and methenamine silver or direct fluorescent staining reveals the disc-shaped cysts. First-line treatment is trimethoprim. Sulfurvescent staining reveals the disc-shaped cysts. First-line treatment is trimethoprim sulfamethoxazolate. If PaO2 is low, add corticosteroids. Prophylaxis with TMP-SMX begins when CD4 drops below 200. Use the CD4 thresholds. Below 200, think PCP. Below 100, think Toxoplasma and Cryptococcus. Below 50, think CMV and MAC. Choice C, CMV, causes retinitis and colitis at CD4 under 50. The disc-shaped cysts on silver stain plus CD4 of 1T point directly to pneumocystis. Read the command, immunologic mechanism, known allergen exposure, minutes onset urticaria, angioedema, wheezing, hypotension, anaphylaxis, a type I hypersensitivity reaction. Anaphylaxis is the systemic form of type I hypersensitivity. On first exposure, the allergen drives production of allergen-specific IgE, which binds the high-affinity FcRI receptors on mast cells and basophils. This is sensitization. On re-exposure, the allergen cross-links adjacent IgE molecules on the mast cell surface, triggering immediate degranulation. Preformed histamine and newly synthesized leukotrienes and prostaglandins cause vasodilation, hypotension, increased vascular permeability, angioedema, urticaria, and bronchoconstriction, wheezing. The treatment is intramuscular epinephrine. Choice A is type 2 cytotoxic antibody against cell surface antigens. Choice C is type 3 immune complexes. Choice D is type IV delayed, T-cell mediated, like contact dermatitis or PPD. The immediate IgE-driven mast cell reaction defines type A. Give epinephrine first. Block 3 is done. Let's review the 5 biggest traps from this block. Trap 1. Distinguishing iron deficiency from anemia of chronic disease. Both are microcytic, but the iron studies are mirror images. Low ferritin and high TIBC means true iron deficiency. High ferritin and low TIBC means iron is sequestered, chronic disease. Trap 2. The AA gradient. A normal gradient with hypoxemia means the lung is fine. Hypoventilation or low inspired oxygen. A widened gradient points to a gas exchange problem. This single calculation directs the entire differential. Trap 3. PPV versus sensitivity. Sensitivity is a fixed property of the test. PPV depends on prevalence. In a low prevalence population, false positives pile up and PPV drops, even with a great test. Do not confuse the two formulas. Trap 4. Immunofluorescence patterns in glomerulonephritis. Linear means anti-GBM, good posture. Granular means immune complexes, lupus or post-streptococcal. Palsy immune with no deposits means ANCA vasculitis. The pattern tells you the disease. Trap 5. Pheochromocytoma management. Always alpha block first with phenoxybenzamine, then beta block. Reversing the order leaves alpha receptors unopposed and can trigger a hypertensive crisis. This sequence is a classic exam point. Train process, not memorization. 20 more questions behind you, 5 more traps you will recognize on exam day. StepLogic. Learn how to think, not memorize.